Thank you very much, Dr. Hazim. The next speaker, Dr. Omar Elkashef, and he will talk about craniocaudal approach for CBT.
Slide. So, the craniocaudal approach for excision of carotid body tumor is one of the best approaches. As we know, the carotid body is formed of two types of cells. Type 1, glomerulus cells from neural crest cells, and type 2 from mesodermal tissue. And the arterial blood supply is well described now as the lower feeder from the glomus arteries or glomic arteries passing through the Meyer ligament. It is a branch from common carotid artery or the external carotid artery, while the upper feeder is the descending musculospinal branch of ascending pharyngeal branch of external carotid artery, and I will refer to it as the descending branch in the coming talk. Occasionally, this is the descending musculospinal branch from the ascending pharyngeal, which is considered now the main blood supply of the carotid body. Occasionally, there may be branches from superior thyroid, aberrant thyroid artery, the facial, occipital, and sometimes from vertebral arteries. In CTA, we can identify the feeders of the carotid body. We have the occipital, the ascending pharyngeal, the descending branch, and the glomic artery as seen. Carotid body present as painless, firm, slow-growing, pulsatile neck mass, mobile horizontally. It can present as hypoxemia or sporadic cases, part of syndrome, familial, specific mutation, and malignancy. Diagnostic biopsy should not be done because of highly vascular and rarely malignant. Biochemical screening is done if positive family history to diagnose functional tumor, but the main investigations are ultrasound examination, MRI, and CTA, which gives a rare sign on CTA that is displaying of the carotid bifurcation. CTA is important as gives information about the tumor and its elevation and the distal part of internal carotid. Old Chamberlain classification classify carotid body tumor into three types: small, large and larger, but the modified Chamberlain grading of lunar aortas is a radiological classification which classify carotid body tumor into type 1 with partial infiltration of internal carotid encircling up to 100 degrees and less than 4 centimeters, type 2 partial infiltration up to 270 degrees but less than 4 centimeters, type 3 partial infiltration more than 270 degrees and more than 4 centimeters. This is a case of modified classification type 3 with partial infiltration of internal carotid more than 270 degrees. So surgical resection is the mainstay of treatment of carotid body tumor, and the small tumor are easier to remove and should be done early because small tumor are easier to remove. The tumor is locally invasive and may be extend up to skull base and involve the cranial nerve and may develop malignant behavior. Surgical excision should be done after preoperative embolization or supraselective feeder vessel embolization if indicated. The aim to minimize blood loss, decrease tumor size, facilitate excision of carotid body, and the major risk is the flux of particulate material into the cerebral circulation or ophthalmic circulation and the stroke. So because of all of that, should be done in Chamberlain type 3, or if the tumor is more than 4 centimeters. Surgical excision should be done the same day or within 48 days of performing preoperative embolization to minimize revascularization, development of collaterals to the tumor. There are two types of approaches to carotid body tumor: dissection in caudocranial direction, starting at the origin of external carotid artery in a cephalic direction subadventitial plane, either with loops or microscope supplemented with bipolar cutter. The other type is the cranial coder approach, and it is recommended, advised in Chamberlain 2 and 3, where the tumor feeder are irrigated before the tumor and the internal carotid are manipulated. This is because the main feeder vessel is the descending branch of ascending pharyngeal, as I said before. These are the steps simplified in sketches. This is exposure of 4 nerves. What are these nerves? The accessory nerve, the hypoglossal nerve, the vagus, and the superior laryngeal nerve, and this is the first step in this approach. The sternomastoid artery should be find. This is sternomastoid artery is a small branch from the occipital artery going to sternomastoid muscle, and this is very important because it has a relation to the hypoglossal. The hypoglossal nerve is slung down by this artery, and after ligation, exposure of this artery and ligation, we can manipulate the hypoglossal nerve up, and the hypoglossal can be manipulated up and medially away from our field. This is important because we can obtain an extra length of internal carotid if we need to do interposition, graft, etc. So after that, we manage the upper feeder, the descending branch, as in the following sketches. This is the descending branch of ascending pharyngeal, which should be irrigated, and the tumor is dissected down, and after that we irrigate the glomic arteries, and this is an actual case. The first step is exploration of the descent and dissection of the artery sternomastoid. After that, we manipulate and dissect the hypoglossal up, and then this is a descending branch exposed and ligated, and this is an extra branch from occipital artery identified and ligated, and after that we dissect the tumor down, reaching to the glomic arteries, and sometimes we find more than glomic artery from the common carotid artery bifurcation or the external carotid. And this is the operative field after finishing the operation with the 4 cranial nerves, the 3 cranial nerve and superior laryngeal exposed and intact. So, in conclusion, carotid body tumor are rare but important disease. It needs sophisticated technique and excellent expertise, should be operated upon by vascular surgeon or at least by a team including vascular surgeon. The craniocaudal approach is more safer during carotid body tumor. My reference is Basic of Vascular and Endovascular Surgery. It is a completely non-profit edition since 10 years. Thank you.